Hey everyone, it's Nurse Mike here from SimpleNursing.com. Today we're going to be talking all about lab values. But before we get started, for my Simple Nursing members, we're going to make sure this information actually sticks. So be sure to follow along with the study guides we show you right up here. From the first section, you'll want to have these two study guides from your membership ready to go.
Starting with BMP, our basic metabolic panel. This is collected typically as a general survey of a patient when they come into the hospital for any reason. Sort of like a sampler platter at a restaurant. We get a lot of different tests and are able to see a wide variety of stuff. So for electrolytes, we have sodium, Na, which remember, sodium swells the body. We have K for potassium, so just think potassium pumps the heart muscles. And chloride, which no one really cares about, to be honest, helps to maintain acid-base balance, which we'll break down all the main electrolytes in a moment. CO2 is carbon dioxide, which helps to maintain acid and base pH balance. I call it carbon diacid, since too much can put the body into an acidotic state. This area can also have HCO3, our bicarb, which also maintains pH balance, pushing the body into an alkalotic state. So just think base for bicarb. And we have the two kidney labs, BUN and creatinine. So just think two labs for two kidney functions. Now the biggest one here is creatinine. Usually if creatinine's high, then the kidneys have died. And if BUN only is elevated, then usually we have burn buns, or basically dehydration. Now glucose is our sugar reading. If it's really high, we have hyperglycemia, typically for clients with uncontrolled diabetes. Or if it's low in hypoglycemia, this one is very deadly, since the brain might die. Clients can slip into a diabetic coma here, typically from missing a meal or having too much insulin in clients with diabetes. So just think hypogly, the brain might die. And there you have it, the good old BMP. We actually sing about this in our Metabolic Panel song on YouTube. It's a parody to the music video for Gangnam Style. So I'll play that segment right now.
Hey nursing students, confused with BM Panel. Get 3 hours of nursing help subscribing to this channel. Many nursing subjects are pretty tough to handle. Let's simplify this BM Panel. Concentration, an indication, dehydration, too much solute, blood, lymph, and vascular spaces, hemodilution, an indication, overhydration, increased fluids in blood and vascular spaces. Nursing students, you need to know your BMP. If you don't, starts with sodium, potassium, calcium, BUN, CO2, glucose, and creatinine. Metabolic panel. Metabolic panel. Do you know the metabolic panel? Metabolic panel. Do you know the metabolic panel? Hey, nursing students. Do you know the metabolic panel? Hey, nursing students. Do you know the metabolic panel? NACA, they aid in muscle contraction. BUN, creatinine, and they test the renal function. CO2 measures your body's acid production. Glucose, sugar consumption. Concentration, an indication, dehydration, too much solute, blood, lymph, and vascular spaces, hemodilution, an indication, overhydration, increased fluids in blood and vascular spaces. Nursing students, you need to know your BMP. So if you don't, starts with sodium, potassium, calcium, BUN, CO2, glucose, and creatinine. Metabolic panel. Metabolic panel. Do you know the metabolic panel? Metabolic Panel. Do you know the Metabolic Panel? Hey, nursing students. Do you know the Metabolic Panel? Hey, nursing students. Do you know Metabolic Panel? Know the norm. Trending what's out of norm. Get a tattoo of lab panels on your arm. Know the norm. Trending what's out of norm. Go to simplenursing.com for more. Know what I'm saying? Nursing students. Do you know the Metabolic Panel? Nursing students. Do you know Metabolic Panel?
Wowza. Okay, hopefully you like that song. You can get it for $1 on iTunes or Google Play for Android. We also have 8 other songs in the full album. Just search Simple Nursing in your music store. Now, as promised, here are the top electrolyte labs that you need to know for the NCLEX here. So sodium 135 to 145. Remember the double S's of sodium. Sodium swells the body with fluid. So with low sodium, we end up with low and slow signs and symptoms. Mental status change is a priority, as well as seizures and coma and respiratory arrest from low and slow respirations. And in high sodium, we get big and bloated, since it swells the body with fluid. So we see edema, our swollen body, increased muscle tone, and flushed red and rosy skin signs. Now for potassium, this is 3.5 to 5.0. Now this is the number one electrolyte to know for the NCLEX and nursing exams. So just think of the 3 P's of potassium. So potassium is priority since it pumps the muscles. So let's cover all the key points from our MedSurg video here. So just think high potassium, we have high pumps. So we get peak T waves and ST elevations for potassium over 5.0. And the exact opposite for low potassium below 3.5, just think low pumps. So we get flat T waves and ST depression, and even this weird little U wave. What the heck's a U wave? Shut up, you. Now we have potassium wasting and potassium sparing diuretics. Potassium wasting ends in "ide" like furosemide or hydrochlorothiazide. Both rhyme with dried. But again, be careful, not isosodide. That's a nitrate, guys. The NCLEX will try and trick you. So remember the O's in isoso make it a vasodilator, similar to nitro. Now, loop diuretics like furosemide and torsemide are the first drugs we use in acute or that worsening heart failure. So NCLEX keywords like worsening crackles, new edema in the legs, and even rapid weight gain. Guys, we give ides to make the body dried. These guys work by blocking the reabsorption of sodium in the kidneys. So with less sodium retained, we have less swelling retained, and our patient is saved. Now, we only give potassium wasters if potassium is normal, between 3.5 and 5.0. Anything less than 3.5 is a big no-no, guys. We don't give the drug. So we encourage our patients to eat melons, bananas, green leafy veggies, and even liver. And a big no-no here, we avoid licorice root, which lowers potassium, like those found in black licorice candy. That's a common select all that apply question. So just remember the double L's here. Licorice lowers potassium. Now, potassium-sparing diuretics, S for spironolactone, just think S for spares the potassium. Just like Prils and Sartan, this spares potassium too. But instead of blocking the angiotensin, this guy blocks aldosterone directly to let fluid out of the body and into the body. And it ends in tone, so think it blocks aldosterone. Since spironolactone spares the potassium, we teach patients to avoid those potassium-rich foods, guys. So we don't eat those green leafy veggies, those melons, avocados, and we avoid that salt substitute. And again, any potassium abnormality, the first nursing action is to place them on a cardiac monitor. Always asked on the NCLEX and exams as a priority intervention. Lastly, since potassium pumps the muscles, NCLEX keywords like muscle spasm and even muscle cramps This indicates a potassium problem. Even words like weakness or paresthesias. So with potassium wasters that lower potassium, think low pumps in the heart. We get flat T waves and ST depression. And also this little weird U wave. Now a little side note, if you have to replace potassium via IV, well, guys, don't kill your patient. We never push potassium IV. This means instant death. So the 4 rules of potassium revolve around protecting the heart with potassium. Number 1, our first action is heart monitor placement. And secondly, guys, we never push potassium. This means sudden death. The heart will cramp up and not pump anymore. Third, we only do 10 to 20 mLs max per hour. Not 30 minutes, not even 45 minutes, guys, per hour, a full 60 minutes or more, usually around 4 hours. And lastly, we always put potassium on an IV pump. Never a solo drip, guys. It's too risky. And as always, slow the infusion pump if the arm starts burning, which is pretty common.
Okay, now that you know how to fix the low potassium, well, how do you treat the high potassium over 5.0 with those high pumps in the heart, leading to deadly cardiac dysrhythmias? Now, this gets a little tricky here. The NCLEX loves to ask about clients with renal failure or chronic kidney failure who have built up a lot of potassium waiting for dialysis, since their kidneys are broken and can't urinate out that potassium from the body and into the body. So let's play a segment from our renal failure videos. So key terms to know. Peak T waves happens when potassium is 6 to 7 microequivalents per liter. ST elevation happens when potassium is between 7 to 8. And wide QRS complexes is a late sign, over 8. Basically, the heart is cramping up from too much potassium. Too much high pumps makes a very tight heart that is just basically cramping all up. You have to think that the heart's a muscle, right? So do you really think the heart can pump normal if this muscle is cramping? Well, no. So this leads to bradycardia, that low heart rate, since the heart is too tight and can't beat correctly, and which ultimately results in weakness, fatigue, and lethargy from less cardiac output, meaning less oxygen out of the heart into the body. And then finally leading to deadly ventricular dysrhythmias like VTach and VFib, that ventricular tachycardia and ventricular fibrillation. If not treated immediately, this will cause death by cardiac arrest, basically that stopped heart. So that's why potassium is priority on the NCLEX and nursing exams, since it pumps those heart muscles. Now, Kaplan had a scenario asking, a client with kidney disease is very weak, lethargic, and bradycardic, asking for a suspected finding for this patient. So the key term here is kidney disease, that is weak, lethargic, and bradycardic, that low heart rate. So you have to automatically prioritize and think about potassium here. So potassium 8.5 is the lab value to be suspected. Now, in terms of treatments, the long-term solution is to wash the blood with dialysis, but this can take some time to set up. So the immediate priority solution and treatment is to lower the potassium and protect the heart from deadly dysrhythmias. We do this with drugs in a very specific order. So write this down for priority treatment. Number 1 is IV calcium gluconate. For the key term, write this down, dysrhythmias. Just think gluconates helps to glue down those crazy heart muscles, preventing deadly dysrhythmias like wide QRS complexes, which will eventually progress into deadly VTach and VFib. We must glue down those heart muscles with calcium gluconate. Now, if the key term of dysrhythmias is not involved in the question, then we progress to number 2, which is IV 50% dextrose and regular insulin. This helps to lower the potassium. So just think, insulin puts sugar and potassium into the cell, out of the blood and into the cell, which lowers blood serum potassium. Most effective way to lower blood potassium very quickly. But insulin also lowers blood glucose too,
basically that blood sugar. So that's why we also give dextrose to help prevent that low blood sugar, that hypoglycemia. Now, don't let the NCLEX trick you here. What if the key term dysrhythmias is not in the question? Well, then we progress to option 2, which is just to give the IV dextrose and insulin first to lower that high potassium. And lastly, 3 and 4, we can also give K-oxalate, that polystyrene sulfonate, as well as dialysis. But again, these typically take longer to lower potassium, so that's why we put them last here on the list, because they take a longer time.
Now, pulling from our Simple Nursing NCLEX question bank, written by the people that actually wrote the NCLEX. Here are the top missed test questions.
So question number 1, a patient with chronic kidney disease missed 3 dialysis sessions. With key terms here, potassium level of 8.1, wide QRS complexes, a heart rate of 58, and lethargy. Which order or prescription should the nurse implement first? So the key term here is high potassium with wide QRS complexes. That key term indicates dysrhythmias. So just think, you have to give calcium gluconate first to glue down those crazy heart muscles and prevent the progression into those deadly heart dysrhythmias. So option number 4, IV calcium gluconate, because the key term was about dysrhythmias and high potassium. Now, question number 2, end-stage renal disease with a potassium of 7.2, a BUN of 35, creatinine of 38, and urinary output of 300 mLs in 24 hours. Which order is priority? So this question says high potassium, right? But nothing about ECG dysrhythmias, or basically heart dysrhythmias. So we need to lower that potassium first with insulin, which puts sugar and potassium into the cell. So option number 1, IV regular insulin and 50% dextrose. Yes, we give this first. Not loop diuretics and not dialysis. This is used later. And definitely not option number 4, the vacation time, even though it's pretty tempting.
For a deep dive into everything you need to ace the NCLEX, be sure to check out our NCLEX Review lecture series and live cram sessions, with insights from current professors, former NCLEX writers, and myself.
Next up is calcium 9.0 to 10.5. Think of the double C's. Calcium contracts the muscles, with smooth contractions here when it's in balance. So for low calcium, we have diarrhea, not so smooth contractions of the GI tract. And we have 2 dance moves, T and C. We have trousseaux, is a twerking arm with the BP cuff on. And for C, we have shavastics, or just vostics. Think C, the cheek smile when stroking the face. And for high calcium, just think high contractions. We have stones, moans, and groans. So all that calcium leads to kidney stones. And high contractions inside the GI will lead to constipation. Next is magnesium, 1.3 to 2.1. Just think of the double M's. Magnesium mellows out the muscles. So low magnesium, we get low mellow, basically hyperexcitability, the opposite of mellow. So we have torsades de pointes and V-fib, 2 deadly cardiac dysrhythmias that will kill your patient. So write those down. Remember, on the NCLEX, the most deadly complication is the most tested complication. Next is hyperreflexia, as well as increased DTRs, those deep tendon reflexes. And for high magnesium, we have high mellow. Everything is just mellowed out. So decreased DTRs and hyporeflexia here. Now for the CBC, the complete blood count. You've probably seen this chart in the hospital during your clinical rotations. So on the left side, we have WBCs, the white blood cells. These are the immunity of the body. In the middle, we have the H&H, hemoglobin and hematocrit, the whole blood inside the blood vessels. And on the right, we have platelets, our little blood clotting proteins that help to form scabs when we get cut. But it also creates blood clots too, which can kill. So starting with H&H, hemoglobin and hematocrit. Hemoglobin by far is the one to know for your NCLEX and nursing exams. It's the part of the blood that carries around oxygen. So the normal range is between 12 to 18. Now, this is the general range for men and women. I know they vary a little bit different, and books and hospitals will differ greatly. So on the NCLEX, they won't have you specify between ages directly. They're mainly going to focus on how low numbers will kill your patient. So be sure to write these down. It's very risky when it goes between 8 to 11. So we must report this to the HCP and surgeon if it's before surgery. Typically, it's due to bleeding or anemia, or even malnutrition and cancers. Now, a critical one, write this one down. Below 7 sends your patient to heaven, or they're going to get a blood transfusion. It's either one of those two options. So the top signs and symptoms to know for the NCLEX is pale skin, also called pallor or dusky skin tones, as well as cool, clammy skin, and fatigue and weakness. So once again, write that key number down. Below 7 sends your patient to heaven. And the top number one sign and symptom is the skin tones and the cool, clammy skin there. So Saunders mentions, the client with a hemoglobin of 10.8 is most likely caused by which condition? Iron deficiency anemia. The key term there is anemia, basically meaning low blood counts. And another question, the nurse determines that the hemoglobin level is normal if which value is noted on the laboratory report? And the answer is 14. Now, as far as the other H in H&H, our hematocrit, which I call hematocreek, like a creek or a river that flows, since it's the ratio of red blood cells and total blood volume, like the liquid part of the blood. Now, normally it's between 36 and 54. So elevated hematocrit is from dehydration. And the memory trick we use is when labs are high, then the body is dry. Now, this is due to hemoconcentration, so we use the memory trick. Hemoconcentration is an indication of dehydration. Now, for decreased hematocrit, this is from fluid volume overload. The labs are very, very low. Just think the body is very liquidy. So when the body is liquidy, we get low labs, which I call low liquidy labs. Now, hemodilution is an indication of overhydration. Or it could be from bleeding, anemia, and even malnutrition. So Saunders mentions, a client diagnosed with fluid volume overload, the nurse would expect to know which finding on the hematocrit level. Decreased. Yes. Remember, low liquidy labs here. And a second question here. A client with a gastrointestinal bleed, laboratory results of a hematocrit level of 30%. Which action should the nurse take? Report the abnormally low level. Yes, we must report these critical labs here. Now, the H&H ratio is easy to calculate. It's a 1-to-3 ratio. So if you only have a hemoglobin level, you can estimate the hematocrit too. So let's just say the hemoglobin is 12, just times it by 3 and it's 36. Or if the hemoglobin is 18, then the hematocrit would be 54. Or let's just say from that Saunders question, you were given 30% for the hematocrit level. So divide that by 3 and you have a 10 hemoglobin level. Very, very bad. You must report that to the HCP. Now, in terms of red blood cells, our RBCs, it should be between 4 to 6 million. So below this, in our low RBCs, this is typically from anemia and renal failure. So we give our clients iron in vitamins or foods like spinach or green leafy veggies. These serve as materials to build the blood. We can also give erythropoietin, which is a hormone released by the kidneys to produce those RBCs. So when the kidneys fail, the erythropoietin fails too. Now, if it's high, this can be from dehydration. Remember, high labs means the body is dry. Next, we have the white blood cells, the police of the body, protecting the body from infection. So WBC total count normally is between 5,000 to 10,000. Higher than 10,000 is what's known as leukocytosis. This is present with infection or sepsis, the blood-borne infection. And even steroids can cause this too. So steroids end in zone, like prednisone. So both of these can cause the WBCs to be higher than 10,000. Now, when the white blood cells are lower than 5,000, this is known as leukopenia and typically results from chemotherapy and radiation where bone marrow suppression takes place, as well as immunosuppressants and even lupus, the autoimmune disease where the body attacks the bone marrow. Since the bone marrow makes blood cells, both white blood cells and red blood cells. And all these conditions lower the bone marrow. So a big thing to watch out for is neutropenic precautions, a huge priority for any low WBC count. So watch for a low-grade fever. That is priority. Since the body is suppressed and the immunity is low here, a low-grade fever typically means a bad infection. The patient should have a private room, no fresh fruits or flowers, avoid sick people as well as crowds, and no drinking water from a pitcher or water that has been sitting out for more than an hour. Now, the second thing to know here is the CD4 count, normally over 200. Anything below 200 indicates AIDS, the active form of HIV. But we cover more of that in the HIV lectures. So a common exam question: which blood laboratory test result should the nurse report to the HCP? Select all that apply. A hemoglobin of 6. Yes, less than 7 sends the patient to heaven. Must report here. How about a potassium of 6.5? Yes, that's way over 5.0. Remember, potassium pumps, so we'll get high pumps in the heart, leading to ECG dysrhythmias. How about a sodium of 150? Yes, the normal range is between 135 to 145. Sodium will swell the body here, leading to edema. And white blood cells of 2,000. Yes, remember, 5,000 to 10,000 is normal. So having less than 5,000 means that we have no defenses. Huge risk for infection here. And lastly, a platelet level of 45,000. Yes, anything less than 150 gets very risky. Now, that was a little bit tricky because we haven't covered platelets yet, but we'll do that right now. In terms of coagulation panel, the 3 labs to know are platelets, PTT, and INR. The key points to know is that the lower the platelets go, the more bleed risk. And the higher the PTT and INR go, the higher the bleed risk. So these are the most tested out of 5 different exam question banks. PT was mentioned, but not directly tested. So don't focus on that directly. So the platelets, the key numbers are 150 to 400, or 150,000 to 400,000. So we notify the HCP for anything less than 150. Now, anything less than 50,000 gets very risky. So we just say anything less than 50 gets very risky. The drugs that decrease platelets, just look for the P's here. Aspirin, clopidogrel, brand name Plavix, enoxaparin, our lower molecular weight heparin, as well as heparin. So be sure to write these down and look for the P's to know that they decrease the platelets. Now for PTT, our partial thrombin time, normally between 30 to 40 seconds, but exams really don't ask for normal ranges. The NCLEX will typically ask for max ranges since this will kill your patient. So clients on heparin, the PTT should be between 46 to 70 seconds for therapeutic range. Again, think higher is horrible. And think of the P in heparin as PTT. You must know your therapeutic range. So again, write it down. PTT for heparin should be between 46 to 70. Now, INR normally between 0.9 to 1.2. But again, don't focus on that. Focus on the client on warfarin with an INR therapeutic range of 2 to 3. The key number there is 2 to 3. So just think, warfarin is for INR. Again, think higher is horrible. Now for both PTT and INR, we should never be more than these max ranges. Or key term here on the NCLEX, it should never be 3 times their range or 3 times their normal range. So write that part down. I saw it a few times on various question banks. Now, if you get an NCLEX question about a client on warfarin with an INR of 4.5, now that's way higher than the 2 to 3. Or a client on heparin with a PTT of 100, way over 70 there. What do? Well, number 1, you stop or hold the drug. Number 2 is assess for bleeding. Number 3 is you prep the antidote. And number 4 is you report to the HCP immediately. Always these 4 on the NCLEX. Stop, assess, prep, and report. Since the NCLEX mainly tests you on safety first, and not about tiny various little details. So always focus on the things that will kill the patient first. Therefore, I highly recommend that you focus the majority of your attention on the coagulation panel and how drugs affect it, since the majority of NCLEX questions come from here. So write down these key points from our pharmacology master course. First up, let's cover antiplatelets like clopidogrel and aspirin, aka salicylate. Now guys, let the name help you here. Antiplatelets are just that. They're antiplatelet. They lower platelet aggregation, so we have a less chance of them sticking together and clogging the arteries. So just think AC for aspirin and clopidogrel, brand name Plavix, like AC for anti-clogging of the arteries, preventing platelets from forming clots. Now, the indication is mainly for clot prophylaxis, basically meaning clot prevention. So guys, in heart and brain clot, like an MI or CVA prevention, narrowed arteries like ACS in the heart, or a TIA in the brain, or even PAD in the extremities, or even prevention after a stent or bypass, preventing the reocclusion of that artery there. Now, the HESI key term, we use post-PCI, that percutaneous coronary intervention. Fancy words for cath lab to clear the clot. Again, guys, AC is aspirin and clopidogrel. AC for anti-clot. Now, the mechanism of action, guys, it's very simple. They prevent the platelets from aggregating together or clumping up, sort of like spreading them out like a bunch of plates. Now, the key points before giving, we always assess. So the key numbers here is hemoglobin levels. So anything less than 7, just think you might be sending your patient to heaven. Huge bleed risk there. And also platelets, normally between 150 to 400. So just think anything less than 150 is very iffy. Always notify the HCP. But less than 50 is very risky. These meds should not be decreasing platelet levels. Guys, this is known as thrombocytopenia, basically meaning a huge risk for bleeding. So common questions on exams, they'll give you a scenario of a platelet count about 75,000 or less than 40, guys. What's the priority nursing action? Always the priority is to hold the drug and question the prescription and then notify the HCP. And guys, don't let the NCLEX trick you. Aspirin and clopidogrel, think platelets, not INR, not PTT. That's for anticoagulants in our next section. So key numbers here, 2 to 3 INR for warfarin. Antidote again was vitamin K. So the memory trick, warkin. So warfarin, vitamin K, and in for INR. Just think warkin. And you wonder if it's working since it takes 5 days to reach full effect. Next is 46 to 70 APTT for heparin with the antidote protamine sulfate. So the memory trick was hepit, like the frog. H for heparin, P for protamine sulfate, and PTT for hepit. And since heparin acts fast, just think the frog jumps really fast. A common HESI question here was heparin drip PTT 85 or a PTT of 100. Guys, anything over 70. The priority action here is to, number 1, stop the heparin drip and notify the HCP. Number 2, prepare the antidote, protamine sulfate. And number 3, reassess the labs in about an hour.
Looking for more tips and strategies for questions like the ones we just covered? Well, our Simple Nursing membership includes exit prep lectures and thousands of questions across all nursing school and NCLEX topics.
Now, a common ATI question, a patient on heparin with bleeding at the IV site. What's the priority action? Guys, key term here to know, blood oozing at the surgical incision or IV site. Again, same priority actions here. Number 1, stop the heparin, notify the HCP, prepare protamine sulfate, the antidote, and reassess labs. Now, on the other side, warfarin, we measure INR, and the therapeutic range is 2 to 3, and 2.5 to 3.5 for heart valve replacements. Guys, therapeutic INR was mentioned multiple times across a lot of quiz banks. Now, a side note here, PT, that prothrombin time, we measure that too, but the values were not tested directly on any question banks. Now, guys, the antidote here is vitamin K, which you can think kills the warfarin. So the key term is vitamin K, not to be given if warfarin's within therapeutic range, and not to be given until at least 5 days of warfarin therapy when switching from IV heparin. Now, guys, vitamin K is found in some very specific foods. Key term here is liver and green leafy veggies like broccoli and spinach. Now, the key point for patient teaching is that it should be eaten consistently, guys, and moderation. So just keep the K consistent. Keywords is not increased, not decreased, and not avoided totally. Just a nice, consistent moderation. Now, don't be tricked. Bananas and oranges are okay. That's for potassium. That is a K plus, not vitamin K. Now, a common ATI question is a client on warfarin. Which statement requires intervention? Well, the statement that includes, I will increase my intake of dark green leafy vegetables. Guys, that's a big no-no. Vitamin K. Now, a side note, that's a nice to know. Antibiotics actually increases the risk for bleeding by increasing INR. This is because antibiotics kill the intestinal bacteria that produce vitamin K. And we end up with a vitamin K deficiency, which increases our risk of bleeding. Now, some common exit exam questions here. Giving an INR of 4 or 5. Guys, we're assessing for bleeding and we're getting that vitamin K antidote ready. Or, on the other side of things, the INR of a 2.0 with a patient with ischemic CVA. Guys, we give warfarin to get up to 2.5. Now, for patient teaching, warfarin is taken lifelong to prevent clots, like with patients with atrial fibrillation or artificial heart valve replacements. Typically more prevalent in, key term here, guys, write this one down, mechanical valve replacements. So another key term, we always do frequent blood tests, definitely needed, to check therapeutic range. Now, heparin's different in that it's typically only given for a few days or a few weeks. So heparin IV is usually given after an MI heart attack or a PE in the lung to prevent the clot from growing. And heparin sub-Q ends in parin, like heparin. So just think enoxaparin or enoxaparin, brand name Lovenox, or deltaparin. Guys, these are lower molecular weight heparin, basically a lighter version, sort of like a Diet Coke. They're just less heavy and a less chance of major bleeding, which is a great thing. Now, it's given for a key term, prevention of a DVT after surgery. Now, a common ATI question is enoxaparin. Which statement needs further teaching? Well, the statement that says, I will inject the med into my thigh. Guys, no, in the umbilicus, near the belly button. And I will need frequent blood tests. Guys, no, that's warfarin. Now, we always notify the HCP and clarify the order of enoxaparin if the H&H is even slightly low. Since, guys, we don't know exactly how much blood has been lost. So open fractures and H&H low, then enoxaparin is a no-go. Now, a common HESI question was, a client on enoxaparin, what do you report to the HCP? And the answer was H&H that has been decreased and a blood pressure that is dropping. In that scenario, it dropped by 20 points. So guys, decreasing H&H with decreasing blood pressure usually means blood loss. Now, as far as labs for enoxaparin, our low-weight heparins, we monitor for those low platelets. Guys, we're not monitoring for coagulation studies. So not PTT and not INR. This is the most commonly chosen distractor. Over 30% of students got this wrong. So guys, think of the double P's for parins. So P for parin in enoxaparin, or enoxaparin, is P for platelet focused. So just like aspirin, the key numbers here, platelets should be between 150 and 400. And guys, we hold the med for any platelets less than 50. So less than 50 gets really risky. We hold really any blood thinner. Now, another risk is a deadly condition from any type of heparin. Now, this is called HIT, or heparin-induced thrombocytopenia. This happens if platelets are decreased by half within, key number here, 24 hours after starting heparin of any type. This usually indicates HIT. Guys, very deadly. So think of the triple H's here. H for HIT is when half the platelets are gone within 24 hours after starting H for heparin. Now, for patient teaching, the big contraindication here, and to be honest, for any blood thinner, is key term active bleed, like a peptic ulcer or peptic ulcer disease. And we always avoid any patients with liver problems since the liver makes coagulation factors. So we use the acronym CHANT. C for cirrhosis, H for hepatitis, A for alcohol. Key term on the HESI was a client just drank 6 beers. N for NSAIDs, and the ATI loves to name naproxen and ibuprofen. And T for Tylenol overdose, leading to liver damage. Now, we monitor signs of bleeding, and we notify the HCP ASAP. Keywords used on ATI was black tarry stools, usually indicating a GI bleed, hematuria, or blood-tinged urine, epistaxis, or nosebleed, and even petechiae on the chest, mentioned by HESI, and easy bruising. Now, supplements to avoid completely. No Eggos, guys, like that old waffle commercial. Lego my Eggos. E for vitamin E, G for ginseng, ginkgo biloba, and, well, garlic, and O for omega-3s, and the S is for St. John's wort. Lastly, we avoid trauma, so the big key terms used on the HESI. No small rugs or dim halls. Always well-lit hallways. No brushing hard, we use a soft bristled toothbrush. No flossing. No alcohol-based mouthwashes. No razors, only electric shavers. No constipation, only fiber and fluids, guys. And no contact sports. And we always wear a medical alert bracelet. Now, 3 common test questions. Number 1, when do you hold heparin and contact the HCP? Select all that apply. So guys, heparin, just think HEPIT. We're looking for PTT between 46 and 70. Anything north of 70, we gotta call the doctor. So patient has recent diagnosis of peptic ulcers. So we're gonna be holding that medication. Number 2 is patient has a PTT of 105. Guys, that's way north of 70. What about option 3? Patient has an INR of 4.5. Nope, that is warfarin, not heparin. How about 4? Patient has black tarry stools. Yes, that could be indication of a GI bleed. And patient has a PTT of 25. Well, that's under 46, so just keep on giving the heparin for sure. And lastly, patient is taking ginkgo or vitamin E. Guys, definitely hold the medication. Huge risk for bleeds. Now, question number 2. When do you question the order of aspirin or clopidogrel? Well, guys, the P for platelets, we want it to be over 150. So aspirin and clopidogrel for platelets. So option 1, now the patient has 65,000 platelets. Guys, that's way less than 150, so it's very iffy. Number 2, patient with 1.5 INR. Number 3, the patient with 46 PTT. Again, that's heparin with hepit, the frog, so no, not a platelet thing. Number 4, currently taking warfarin. Yes, guys, we want to hold this medication because we don't mix aspirin or clopidogrel with an anticoagulant. And number 5, regular consumption of 6 glasses of wine per night. Guys, we're not doing alcohol for sure. And lastly, another common question. A patient on dabigatran for AFib, which action should the nurse initiate? So guys, number 1, place an IV line. No, we're not trying to place an IV line here. We indicate a big bleed. Number 2, report stools that are black and tarry. For sure, that's a GI bleed. Number 3, teach the patient to avoid clopidogrel. Most definitely. Number 4, administer aspirin instead. No, big no-no, we do not mix. And number 5, teach the patient to stop taking this med before surgery. For sure, definitely want to do that. Now for the cardiac labs. For an MI or myocardial infarction, fancy words for a heart attack, just know the double T's here. Troponin over 0.5 means trauma to the heart muscles, basically cell death. Now I know there's a lot of other nice to know cardiac enzymes, but real talk here. Those are typically not tested on the NCLEX or exit exams. So I wouldn't recommend using your precious time memorizing all the other cardiac enzymes. Because the one to know is troponin, coming up 99% of the time on many question banks. Out of 10,000 questions, troponin was the only cardiac enzyme. Now for CHF, or congestive heart failure, just think of the double B's. BMP under 100. Think big, stretched out ventricles if that BMP is high. Now it's not a high priority, so again, I wouldn't focus on this since it indicates chronic long-term condition. But if you want to impress your clinical instructor, then watch this next 3-minute segment. Now, what the heck are natritic peptides? Well, the medical definition are hormones secreted by cells that lie in the heart chambers when there is damage presented. They're simply a good way to determine if the chambers in your heart are being stretched out too much for a buildup of blood pressure in the heart. Now, we have 2 types of natritic peptides. The first type is ANP, atrial natritic peptides in the atriums, the upstairs of the heart. Next is the BNP, the brain natritic peptides, in the ventricles, the downstairs of the heart. It's kind of like a speedometer hormone to show us how bad the damage in the heart actually is. So more hormone that is present, the more damage in those ventricles. Now let's dive a little deeper into our brain natritic peptides, which is vital lab for our heart failure patients. Now I want you guys to think very, very simply here. If the heart has to work harder than usual over a long period of time, from all that high blood pressure being pushed on it, maybe from a super high sodium diet, maybe from a sedentary couch potato lifestyle, or even high cholesterol foods, or even renal failure holding all that fluid inside the body. Ultimately, BNP is the biggest indicator for heart failure. The heart releases more BNP to the measure and degree of the wear and tear or the deterioration of the ventricles, mainly the big mama ventricle on the left. Now, atrial natritic peptides are very different than BNP. They're not necessarily a marker that measures the wear and tear on the heart. ANP are kind of like a special forces that tries to assassinate aldosterone in the kidneys. Because aldosterone is the bouncer or security guard in the kidneys that holds sodium and fluid in the body. So ANP is secreted as kind of a defense system in response to increasing blood pressure and increasing blood volume, which stretches out and damages the heart tissue. The atrial natritic peptides act like the special forces because they go down into the nephron, into the functioning unit of the kidney, and they create an opposite effect of aldosterone. So now in the kidney, the reabsorption of sodium is blocked, and at the same time, the filtration rate of the kidney is increased. So what happens is we have a release of fluid from the body and into the potty. All fancy words for ANP done killed aldosterone. So all that water flows out of the body and into the potty. Now it's technically kind of bad when ANP levels do increase because this indicates a war is going on. And this happens with acute heart failure or SVT, supraventricular tachycardia, even hyperthyroidism, and even in small cell lung cancers. But interestingly enough, levels actually decrease with chronic heart failure. And critically think this for a second. It's because ANP gets worn out over a long period of time.
it gives up in the battle. Basically, the body can't do everything to combat this high blood pressure. So that's when our patients get put on drugs like ACE inhibitors, ARBs, or potassium-sparing diuretics, in order to finish the job your body was unable to do. So in closing, please understand that even before we give your patients any type of medication, your body already has tried numerous backup plans to try and fix the problem. This will be called a self-regulation process.
Now for the acid-base ABGs. Oh no! The key numbers that you need to know is a pH of 7.35 to 7.45, a PaCO2 of 3.5 to 4.5, and an HCO3 of 22 to 26. So write these out at least 5 to 10 times the week of your exam. And I recommend using the marching band suit method to interpret ABGs, found in our full ABG video, and really not the Rome or tic-tac-toe method, and I explain why in the full ABG video. Now for pH 7.35 to 7.45, anything less than 7.35 is acidic blood. This one is the most important here. Now over 7.45 is alkalotic or base blood, which has a higher pH, which generally is not as important as acidosis, as acid can lead to respiratory failure. Next is PaCO2, 3.5 to 4.5. You see, we just dropped the sevens there. So for carbon dioxide, just think carbon diacid. Under 3.5, we get alkalosis, or that base state, typically from hyperventilation, or basically blowing off all that carbon diacid, or carbon dioxide, which leaves the body into an alkalotic state. So the memory trick we use for respiratory alkalosis, that fast breathing, just pant like a dog, alkalosis. Or you can think of the double A's here. Anxiety attack for hyperventilation will lead to alkalosis. So Kaplan mentions the cause for respiratory alkalosis is hyperventilation. So we simply treat the patient by breathing into a paper bag to slow down the breathing and retain that CO2, that carbon diacid that is lost. Now, if this CO2 is over 45, then this is acidosis, typically from low and slow breathing. The body's retaining too much carbon dioxide or too much carbon diacid. This is far more deadly since it can lead to respiratory failure. So the memory trick for the causes here is respiratory acidosis. Just think anything that can cause low and slow breathing, like a snoring person. Just think acidosis, which retains more CO2, more carbon diacid. So really anything that can cause low or slow breathing. So alcohol intoxication and even overdose with low and slow respirations. And opioids and benzos like diazepam or even alprazolam. Typically, those are the most tested there, so I'd write those down. And think of C in COPD as C for CO2 is retained. Because in COPD, our chronic obstructive pulmonary disease, just think chronic destructive lungs. The lungs are really destroyed here. And lastly, we have sleep apnea and head trauma, which can lead to low and slow breathing. So the key treatment to get rid of all this CO2 is hyperventilation. We use pursed lip breathing to blow off all that CO2. So just think we have to pant like a dog, and that'll put you into alkalosis. Now for severe acidosis, this is called hypercapnic respiratory failure. Just think high CO2 for hypercapnic respiratory failure. An example is a client with a pH of 6 and a CO2 of 65, way off there. So the key treatment for hypercap is to give a BiPAP. And if that doesn't work, then we have to intubate and ventilate. Lastly, we have HCO3, 22 to 26. This is our bicarb, which we remember as a bicarb is our base. This helps to balance out the acid. So the memory trick for the causes, for metabolic alkalosis, just think of vomiting like alkalosis, or NG tube suctioning. We're basically sucking out all that stomach acid out of the body, And now the body's only left in a base or alkalotic state. And for metabolic acidosis, we have diarrhea, like you're pooing out of your acidosis. The body gets rid of all the base in diarrhea, and so the body's left in an acidotic state. Or even in renal failure. So just think when the kidneys fail, acid prevails. This happens because hydrogen ions inside the urine means high acid. So in renal failure, you can't urinate, retaining all that high acid hydrogen in the body and not in the potty. And lastly, the PaO2 should be 80 to 100%. Hypoxia's earliest sign is mental status changes. And the top 3 on the NCLEX to know is number 1, restlessness. Number 2 is confusion. And number 3 is agitation. So write these down. They're always key terms for hypoxia. Now, in terms of the highest priority, just think safety. We call it loss of life and loss of limb. So for ABCs, airway breathing equals oxygen. So low PaO2 or high CO2. Again, we're looking for mental status changes with restlessness and agitation. And even for skin signs like pale, dusky, and even cool and clammy. Those are typically the most tested out of 10,000 questions. Now for C in the ABCs, for circulation, the top 4 to know, number 1 is bleeding. Look for the high PTT and high INR. Remember, you have to know your ranges. Number 2 is shock. Think severely low blood pressure. Low blood pressure will kill the patient, and so will bleeding. Number 3 is chest pain of any kind, even heartburn or anything really. Chest pain is a priority. And number 4, hypertension crisis over 180 systolic is critical. Now the NCLEX usually won't pit these kind of patients against each other. They'll put them in a random bunch. Now in terms of infection, the priority here is less than 5,000 WBCs, known as leukopenia. High risk for infection. And for kidney labs, the real big one to know is creatinine over 1.3 is bad kidney. We get loss of organ here, and bad kidneys will actually lead to toxicity all over the body. And for pain, our last one here, this is manageable. It's not technically going to kill someone, unless it's chest pain, of course. So ask yourself, will the patient lose life or limb? So chest pain is number 1 priority. And number 2 is the loss of limb when we're talking about pain. So compartment syndrome. If the question states that the client just had a cast placed or if the limb is broken. And key terms here, unrelieved with pain meds like morphine or hydromorphone. The key term is unrelieved pain. The client may lose their limb due to compartment syndrome. So pause the screen and write these key terms down, and you'll know how to prioritize your patients for the NCLEX and your nursing exams. Okay, now for a deeper dive and more specifically for airway and breathing. Let's talk about oxygenation. So for ABGs, not the pulse oximeter, a PaO2 is 80 to 100. That's normal. 60 or less is hypoxemic respiratory failure. Very low O2. Patients can go into respiratory failure and die. And again, a PaCO2 of 35 to 45 is normal. 50 or more can lead to hyper-C or hypercapnic respiratory failure. Just think high CO2 for hypercapnic. So once again, hypercappy, we give a BiPAPy, or we intubate and ventilate. Now, more specifically for circulation, the bleeding here in terms of prioritization, an INR over 4 and a PTT over 100. What do? Well, number 1 is you stop and hold the drug. Number 2, assess bleeding. Number 3, prepare the antidote. For warfarin, it's vitamin K. And for heparin, it's protamine sulfate. So the memory trick, just think Warkin is for vitamin K. And think of hepit, like a frog. Heparin is PTT. And very lastly, number 4 is we report it to the HCP. Now, after the ABCs, we have to think infection. So the priority is less than 5,000 WBCs is leukopenia. Just think, a low-grade fever will kill. The client has like no defenses here. So watch out for immunocompromised clients, clients on chemotherapy, and those taking immunosuppressants.
Again, pulling from our massive pool of over 4,000 NCLEX questions. Here's a common exam question.
An emergency room nurse is presented with 4 clients at the same time. Oh my goodness. Which of the following clients should the nurse see first? Okay, now before looking at the options, always ask yourself, who dies first? So start with the ABCs, loss of life first, and then loss of limb. So option 1, a client with a low-grade fever, a headache, and fatigue for the past 72 hours. Maybe. The question doesn't really say immunosuppressed or chemotherapy, so it's probably a common cold or flu. Option 2, a client with swelling and bruising to the left foot following a running accident. Well, not really. It seems like a sprain, and it states running accident. Now, it doesn't state pale skin or tingling or unrelieved pain, typical of compartment syndrome. Now, option 3, a client with abdominal and chest pain following a large spicy meal. Yes, we always choose chest pain. Think, am I heart attack here? Now, yes, it could be gastric reflux. It could be heartburn after the spicy meal. It could be a burrito. I don't know. But we must assess any type of chest pain first. And the last option, a child with a 10 centimeter laceration on the chin. No, the client's not dying here, and it's only a chin cut. So you have to ask yourself, who dies first? And it's the third option, the client would die first from a heart attack. Now for cholesterol labs. Let's cover the need-to-know numbers and some patho behind high cholesterol and some pharmacology to treat it in this next segment.
The numbers you need to know for the NCLEX. All land animals increase bad cholesterol, like total cholesterol, triglycerides, and LDLs, the loser lipids. High cholesterol means high clogging, and these numbers love to show up on the NCLEX and exams, so guys, write these down. All these numbers should be low except HDLs, the happy lipids. The only ones that should be high, over 40. So HDLs help get rid of the bad cholesterol. And also, eating fiber found in fruits and veggies can help clean out that cholesterol. Now, what causes this narrowing? Well, fatty deposits called plaque develops on the walls of the coronary arteries, narrowing the vessels, which makes it harder for oxygen to get to the heart muscle. So what causes this? Well, just like hypertension, we use the acronym SODA. S for stress. This can cause momentary narrowing. So anxiety, cold temperatures, even physical exercise like sex. And stimulants like caffeine, even amphetamines like meth and Adderall, also narrows the arteries momentarily. But what really causes the most damage here are irritants found in smoking, which scars the arteries, and long-term obesity. Key term here, guys, a BMI over 25. But also diabetes and hypertension can cause stretching and tearing to the coronary arteries, which severely damages them. Coupled with a bad diet high in cholesterol from animal fats like meats and dairies can cause fatty buildup getting stuck in the cracks. And over time, this growth makes the blood vessels stiff and hard, something we call plaque. This plaque causes hardening and narrowing in the arteries, which is typically called atherosclerosis. So just think arteriosclerosis, hardening of the vessels from the scarring and plaque. Lastly, heart disease is more common in African American males and increased age over 50, and more common in men than women. Maybe women just handle stress better than men. I don't know. Eventually, too much plaque can turn into blockages, and if one of these plaques ruptured, usually from stress, a blood clot can form in minutes. And this blood clot can completely block all the oxygen to the heart muscle. Without oxygen, heart cells die within minutes, releasing proteins called troponin. And guys, this is the #1 indicator of an MI. But we're going to cover that in the diagnostics section. Now, narrowing is classified into 3 sections under the big umbrella of ischemic heart disease, meaning a disease of lower oxygen to the heart. And it comes in 3 sizes, small, medium, and large, kind of like a pizza. So for small, it's called coronary artery disease. Then stable angina, the stress-induced angina, or basically chest pain. Now, medium is ACS, the acute coronary syndrome, which encompasses unstable angina and MI. Now, unstable angina is our unsafe angina, which is unrelieved with rest and totally unpredictable. Far worse because it means we're closer to the larger condition of an MI, and then to death. So typically more pain experienced means more tissue death is occurring. Okay, lastly, we can give two very particular drugs that prevent future MIs. Let's play that segment right here. So think AC for anti-clogging of the arteries. A is for antiplatelets like aspirin and clopidogrel, brand name Plavix. This guy prevents platelets from clumping together and forming clot. And C for cholesterol-lowering drugs. Guys, these end in statin like lovastatin. So remember, stay clean because it cleans out the arteries, keeping them free from cholesterol. Now, since statins prevent the production of cholesterol in the liver, it is very liver toxic. So guys, don't give this to patients with liver problems like hepatitis or cirrhosis. Oh, and also avoid grapefruit juice since it blocks statin drugs.
Now for Diabetic Labs, we have glucose and hemoglobin A1C. It's very important in diagnosing diabetes. So let's play that segment now for our diabetes lecture.
Now, as far as diagnosing diabetes, the top 3 must-know labs for the NCLEX that you will get tested on, guys. Write these down. Number 1, normal glucose must be 70 to 115. Number 2, fasting glucose less than 100. And third, hemoglobin A1C must be less than 6.5. Those are big NCLEX key numbers there. Write those down. Now, as you know, the A1C test is our long 2 to 3 month sugar audit, and is best used to see if patients are being compliant with controlling their blood sugars the long term. So remember, below 6 is controlled and fixed, and over 6.5, we gotta revise. So review diet and exercise compliance for our type 2 problem, basically the U problem. And with type 1, insulin compliance, always on the NCLEX. Now, the most deadly is low sugar, under 70, called hypoglycemia, since it causes brain death. So we say hypogly, the brain will die. Now, all the other numbers on this chart just help diagnose the severity of diabetes, but are not highly tested on the NCLEX. And speaking of something that's not highly tested, a little side note here. The GTT, or glucose tolerance test, is when we give an 8-ounce drink of syrupy glucose to see if insulin is doing its job by putting the sugar into the cell. If it's not, then the sugar will go high. But guys, that's not usually tested on the NCLEX directly. Now, signs and symptoms and causes of high sugar or hyperglycemia. Just think, the blood is turned to mud. So the body tries to get rid of all this thick syrup with the 3 Ps. First P for polyuria, a lot of urine. Basically, the body tries to urinate it out. Now, polydipsia is a lot of drinking fluid. The body tries to dilute all that sugar. Now, third is polyphagia, which is excess hunger as cells starve, since insulin's not doing its job to get sugar inside the cells. Now, a little side note, this is not polyphasia, which is a psych disorder. Now, the causes of acute high sugar can be caused from the 4 S's. The number 1 key term on the NCLEX is sepsis or infection, guys. That's a number 1 cause. But also stress from surgery or hospital stay, and even skipping insulin doses. And a big one here is steroids, those zone-ending drugs like prednisone. That is a big cause. But high sugar can also be caused from hormone therapy like estrogen. Now, we treat that high sugar with insulin to put that sugar into the cells. So for your test, I know that's going to come up. Yes, we increase the insulin during stress like sepsis, surgery, and especially with steroids. And guys, know the patient's not on insulin forever. Once the S's stop, then the insulin stops. And guys, big key word here, if the sugar is still high after the insulin, that's a critical situation. Always call the doctor or HCP. Now on the other side, for hypoglycemia, that low sugar below 70, guys, just think low brain function, which leads to rapid brain death. So remember, hypogly, the brain will die. We're going to be watching for critical signs, the cool, pale, sweaty, or clammy. We need to give that patient some sugary candy. Now, typical NCLEX keywords include high wash. So headache, irritability, weakness or anxiety, and even shakiness and hunger. It's kind of like a Snickers commercial. You're just not you when you're hungry. Now, since hypo is so deadly that hypogly, the brain will die, our very first treatment is giving sugar. So on the NCLEX, if the patient is awake, then we A, ask them to eat. Specifically juice, soda, crackers, and low-fat milk. Not high milk or peanut butter. Big key word right there. The fat actually slows down the sugar absorption. And if they're asleep, big key word here is not alert or unarousable or only arousable to painful stimuli. Then we S, stab them with dextrose IV. And always reassess sugars every 15 minutes after giving insulin. Now, causes of hypoglycemia. They usually come from exercise, alcohol, and even insulin peak times. Big NCLEX tip right there. So watch out for diabetic athletes who exercise. If your patients exercise, then give extra glucose. Keywords, bicyclists, swimmers, and even runners. Now, alcohol is also a big no-no, technically with any disease, but it actually lowers sugar, doesn't increase it. And insulin peak times is when patients are most at risk for that low sugar. So remember, if there's a peak time, then we give a plate of food. Since hypogly, the brain will die. Now, 3 common test questions for that low or high sugar. Here we go. Test question number 1. A client with type 1 diabetes is only responsive to painful stimuli. With a blood sugar of 42, what's the first action taken by the nurse? Guys, this is the worst case scenario here. Anything less than 70 is bad. So hypogly, the brain will die. Now, patient is not alert, only responsive to painful stimuli. So if they're not awake, we can't ask them to eat. Technically, the patient's asleep, so we stab them with dextrose IV, and then we reassess blood sugar in 15 minutes. Oh, and if you chose option 4, I'm shaking my head at you. Question number 2, which medication could cause hyperglycemia? Now, guys, before you even look at the options, you should already be saying steroids increase the sugar ending in zone, like prednisone. So, guys, zone-ending steroids. Steroids increase the sugar. Now, the tricky question number 3. The non-diabetic client is admitted for a kidney infection that has now turned septic. The blood sugars have increased from 150 to 225. What is the best answer to give a family member who's asking why insulin is used? So option number 1, the client now has type 2 diabetes. No, that's a wrong answer. Option 2, insulin is given to control hypoglycemia. Totally wrong. It's for hyperglycemia. Option 3, high sugar is common during infection and stress to the body. And insulin will help lower the sugar until the infection resolves. Guys, yes, option 3 is the best option. Super high sugars, we want to land like a plane, slow and steady. We don't want to crash into that hypoglycemia, that low sugar with low brain function. Now, if you chose option number 4, you nasty.
Now for renal lab values and urine analysis. Again, use the memory trick HOOK, H-U-C, since the kidneys sort of look like a pirate hook. Now H is for hydrogen ions, U is for urea, for blood urea nitrogen, and C is for creatinine. So starting with H, our hydrogen ions, these are very acidic. So during renal failure, we have failed washer machines, right? So acid builds up in the blood, and clients end up in metabolic acidosis. So a pH below 7.35, which damages the muscles, bones, and the kidneys. Now a common test question asks about a list of clients most at risk for metabolic acidosis. So just think here. Metabolic means the kidneys and body, not the lungs here. So anyone with more acid in the body and not in the potty. So option number 1, renal failure. Well, think, are the kidneys broken here? Yes. Well, that means we retain more waste and retain hydrogen ions, that acid. Now, option number 2, pyelonephritis, is that kidney infection. So are the kidneys impaired? Yes. So we retain more hydrogen ions and end up in acidosis. Now, option number 3, a patient waiting for hemodialysis. So we have a patient waiting to get their blood washed with hemodialysis, right? That kidney machine that helps to filter the blood. So the key term here is they're waiting. So the blood is filled with acidic waste. So yes, they're at risk for metabolic acidosis. Now, option 4 is a little bit tricky here. Hyperventilation related to an anxiety attack. Well, this is a tricky one. It's not necessarily the kidneys. We have a risk for respiratory because of the rapid breathing, specifically respiratory alkalosis, that hyperventilation because we're blowing off that CO2. So just think acid. Carbon dioxide, we call carbon diacid. So the memory trick we use, just think of a dog breathing like alkalosis, hyperventilation. Now lastly, option 5, a child with diarrhea for 2 days. Well, yes, they're at risk for metabolic acidosis, but we'll cover more of this in the acid-based lectures. But real quick, diarrhea does cause metabolic acidosis for a different reason. It's because they poo out all their alkaline, that base, inside the GI tract. So just think, base comes out the butt, so clients end up with an acidic body and end up in acidosis. Or just think if it comes out of your acidosis, like diarrhea, well then you'll be left with metabolic acidosis. Now U is for urea, that BUN, blood urea nitrogen. The key number to know for exams is 10 to 20 maximum. Now this is a byproduct of protein waste after the body consumes the nutrients it needs from protein, which I call it the protein bar wrapper, since it's basically the trash that the body needs to toss out. Now, before it becomes urea, it starts as ammonia, which it gets sucked into the liver to be broken down into urea. Then it gets pushed into the blood before it's excreted by the kidneys, from the body into the body. Hence the name blood urea nitrogen, that BUN. So BUN can be high for various reasons, but most commonly due to dehydration. So just think, if the buns are high, then the body is dry, typically. Or we say if you got burned buns, then you stayed out in the sun too long and you got dehydration. So if your buns are burned, then your BUN is typically high because the body is dry. Now C is for creatinine, our most critical kidney lab value to assess kidney function. This one is the one to know by far for nursing exams and the NCLEX. Once again, the key number to know here is over 1.3 means bad kidney. That is the key number to know. We'll be saying it multiple times throughout this renal course. So creatinine is a waste product produced by the muscles, coming from normal everyday wear and tear. So the higher the creat, the higher the kidney impairment, since it shows if the washer machines, the kidneys, are getting clogged up with muscle waste and impairing its function to wash the blood. So the memory trick is the 3 C's. For creatinine, just think critical kidney lab value that shows, third C, clogging of the kidneys with muscle waste, indicating kidney failure or kidney injury. Now for a quick study tip, always focus on the max ranges for pharmacology and lab values. Since the NCLEX and nursing exams mainly focus on how drugs or values will harm the patient. So safety is priority here. They want to test and see if you're going to be a safe nurse. So always focus on the max ranges here. So the key numbers for the NCLEX and nursing exams for renal function, just in case you missed it, BUN is 20 max, creatinine over 1.3, just think bad kidney, and urine output 30 mLs or less, just think the kidneys are in distress. Now a common NCLEX question, a client with infected toe due to diabetes is scheduled for a cardiac catheterization with contrast. Which lab value should the nurse report to the provider? So option 1, blood urea nitrogen level of 19, that is borderline. So no, technically it's less than 20, so we're okay. Option 2, a blood glucose of 155. This one's close, it's a little elevated, but it's typical for diabetic clients. Now option 3 is the one to know, creatinine level of 1.9. Yes, that's way over. Remember, creatinine is the critical kidney lab. So creatinine over 1.3 means bad kidney. And contrast kills the kidneys, which we cover in our cardiac lectures. Now, option 4 is incorrect. A white blood cell count of 14,500. No, elevated WBCs are typical because the key term here is infection, since the client has an infected toe. So we expect those WBCs to be high. And last but not least, we have our UA, the urine analysis. So for color, light typically means hydrated and dark urine typically means dehydrated. Now there are certain cases when this doesn't match up. So, for example, like when we dump too much urine in DI, that diabetes insipidus. So we end up diuresing a lot of fluid and end up with light urine, but a dry body. Or on the other side of things, in SIADH, we stop urinating. So we end up with dark urine and a really fluid-filled body. But we cover that in full detail in the endocrine lectures. Now, for specific gravity, students get this confused all the time, so pay attention here. The key numbers here are 1.003 and 1.030. So let the name help you here. Specific gravity, just think gravity here, the weight of the urine. So the memory trick we use is for light urine with the specific gravity that is low, just think a low and liquidy body. Very dilute urine, so we have a dilute body with low liquidy lab values. And on the other side, for heavier urine, the gravity is high, so just say the body is dry. Now be sure to memorize these numbers because the last thing you want to do is get those zeros and threes confused. Now if you see RBCs or blood inside the urine, this is known as hematuria, typically due to kidney stones, bladder cancer, or even trauma, like after prostate surgery or a procedure. And WBCs, those leukocytes, is general infection like a UTI or a kidney infection. So clients will complain of burning during urination. Now, nitrites, that's a key term there. This is typical for kidney infection like a pyelonephritis. So just think of the N's here. For a kidney infection or pyelonephritis, we check for nitrites. Now, if either are suspected, we can always do a culture and sensitivity test. So culture identifies the bacteria, and sensitivity, which antibiotic is the bacteria most sensitive to best kill it. So we take a sterile urine sample, and the key number here is over 10,000 organisms per ml indicates a UTI. Anything less for a culture is normal. And the last two here, protein and glucose. So if protein's high, that typically means nephrotic syndrome, which I call nerfrotic syndrome, like a bunch of Nerf balls inside the urine. And if glucose is high, that typically means diabetes, that really sweet, sugary urine there. Now, a common NCLEX question gives you an exhibit with all these screwed up UA values. So be sure to focus on the ones that are out of range. So a specific gravity that's high, and a little side note, don't get confused with the zeros and threes. That's a high specific gravity there. Glucose that is high, and leukocytes that are medium. So right off the bat, you're thinking, if it's high, then the body's dry, right? And for glucose, you're thinking diabetes. And leukocytes, I'm already thinking infection. So the question asks, a client with a history of diabetes, okay, which does the nurse suspect? The correct answer is dehydration, some question banks said low fluid intake, and possible UTI, that urinary tract infection. So perfect, the SG was high, so the body was dry, right? Dehydration. And we had leukocytes, so obviously an infection, UTI. Now for Kaplan question, it asked a procedure for collecting a sterile urine specimen from a Foley bag, and it was an order response question. So the correct sequence is, number 1, clamp the drainage tube below the port. Number 2, wait 15 to 30 minutes. Number 3, scrub the port using an antiseptic swab. And lastly, number 4, attach a sterile needleless device to aspirate a specimen via the port. But I wouldn't focus on this one too much. It was the only question out of about 10,000 questions we surveyed here. So I would focus on the critical values. Now, last but not least is our liver labs, the key labs for liver disease patients.
For this section, grab these study guides to keep up with the important points we'll be covering.
Now, in terms of hepatic encephalopathy, as mentioned before, this is that cloudy toxic brain from the high levels of ammonia in that protein. So the key signs to write down is twitching extremities in the arms and legs, known as asterixis, and mental status changes, seen as confusion or bizarre behavior, as well as sleepiness. Now, Select All That Apply questions love to ask about assessments for hepatic encephalopathy. So write this down. The key assessments include assessing hand movements with arms extended. Write that one down. Arms must be extended. Assess mental status with those from the previous shift, and assess recent blood draws for ammonia levels. Again, write those down. I can almost guarantee you it will come up on your exam. Now, the top missed NCLEX question from this section. Which assessment would indicate if a client with cirrhosis has progressed to hepatic encephalopathy? Select all that apply. Ask the client their date of birth, name, date, and location. Yes, these 4 questions are to monitor mental status, to see if the client is oriented. Tell the client to extend their arms. Yes, the key term there is to extend the arms to assess the muscle twitching. And lastly, compare the ammonia blood levels with that of previous shifts. Yes, ammonia levels should not be going up. If they are, it will cause more hepatic encephalopathy. Now, don't let the NCLEX trick you here. For hepatic encephalopathy, we are not assessing the skin for thinning blood vessels like spider veins. And we're not assessing the eyes or skin for jaundice, that yellow skin. These will typically be present with any client in liver failure, not specific to hepatic encephalopathy. So just make sure to know your key assessments for hepatic encephalopathy. Now, Saunders mentions, a client with cirrhosis shows signs of hepatic encephalopathy. The nurse should plan dietary consultation to limit which ingredient. And the key answer was protein. Yes, protein has the ammonia waste. Remember, ammonia is the protein wrapper, the waste around the protein, which causes the hepatic encephalopathy. So limiting protein will limit the ammonia. Now, in terms of liver failure labs, big NCLEX tip, write these down. They love to come up on select all that apply questions. So ammonia will be high, causing the hepatic encephalopathy, our cloudy brain. And the ABCs of the liver will be all jacked up here. So A for albumin, that's going to be low, under 3.5, as well as calcium will be low, since calcium binds to albumin. And we'll also see low platelets. Now B for bilirubin, that'll be high, since our bile bus is out of commission, not scooping up little Billy, our bilirubin, causing the body to become jaundice yellow. And C is the coagulation panel, or the clotting factors. Basically, our clotting times will be high. So we'll have high PT, PTT, and INR. So a higher risk for bleeding. Bruising is very common with these clients. And lastly, we'll have elevated ALT and AST, which are common really for any liver disease client, from cirrhosis to hepatitis and even others. So you really don't need to memorize the ALT or AST numbers. Most exams will give you the ranges. Now, a top missed question, for which blood lab values are expected to be elevated in a client with worsening cirrhosis? Select all that apply. So just slow it down here before you look at the options. So just think ammonia, bilirubin, and prothrombin time, the PT, will all be elevated. The only 2 that are really going to be low is albumin and calcium here, because albumin is that protein that the liver produces, and since albumin binds with calcium, both will be low together. Now, don't let the NCLEX trick you here. They always try and get you to choose albumin and calcium, saying that they're elevated, but no, they will always be low. Now, another sign and symptom is pruritus, that itchy skin. You see, as toxins and bile salts build up under the skin, this causes major itching. Just think about it here. The recycling detox filter, the liver, is broken, so the body's naturally filling up with waste products. So the 4 key points that love to show up on exams and select all the apply questions, it always revolves around protecting the skin and avoiding the scratching. So write this down. 4 key points. Number 1, apply a cool, moist cloth to the affected area to soothe the skin, not a hot shower or a hot bath. Always keep it cool. Number 2 is applying moisturizing cream over unbroken skin to protect the skin. The key term is unbroken skin. So moisturizing cream is good. Now, number 3 is wear long sleeve clothes and cotton gloves to avoid the scratching here. And number 4 is trim the fingernails short to prevent skin breakdown if the client accidentally scratches themselves. So I'd recommend pausing your screen and writing these 4 things down. Now, for a top missed NCLEX question here, A client with worsening liver failure presents to the med-surg floor. Which assessment finding should the nurse expect? Select all that apply. So just slow it down and look at the key terms. Worsening liver failure, and it's looking for an assessment finding here. So, option 1, an enlarged abdomen from ascites. Yes, ascites is that abdomen filled with fluid. And bruising marks all over the skin, yes, from the lack of clotting factors leading to easy bleeding, resulting in bruising. And fatigue and possible confusion, for sure, from possible elevated ammonia levels leading to hepatic encephalopathy. How about sclera that appears yellow? Yes, from jaundice. Remember that building up of bilirubin inside the blood makes the entire skin look yellow like a school bus. So just think of your patient like a little lemon here. It's big and it's yellow and it might have some bruising. And very lastly here is reports of itchy skin. Yes, from all those toxins building up inside the blood. Now for diagnostics, a liver biopsy can be taken to analyze tissues. So key point here is after the procedure, we have clients lay on the right side to prevent bleeding. So we always put pressure on anything that is bleeding. In that same way, we want to put pressure on the liver to prevent bleeding. Now for interventions, there's many here. So write this first one down. For ascites, we do a paracentesis. So again, remember A for ascites is A for abdominal fluid. From all that portal hypertension where fluid now overflows into the peritoneal cavity. So in a paracentesis, the HCP simply pokes the abdomen with a needle to drain the fluid. Now there's a lot of nursing actions prior to the procedure, so write these down. They love to come up on NCLEX questions. Have the client, number 1, empty the bladder to avoid poking or perforating the bladder. Number 2 is vital signs. The key number here is to monitor for blood pressure, since clients who are getting fluid drained can go into shock, meaning severely low blood pressure. Number 3 is we measure the abdominal circumference and take the client's weight. That one is a big one here. It's always tested. And we have to measure how much fluid was taken out of the abdomen. Now lastly, number 4 is head of the bed up in high Fowler's position to keep that fluid in one place and to help the drainage here. So Hesse mentions, a nurse is assisting with a paracentesis for a patient with ascites caused by cirrhosis. Which action should the nurse take first? Have the patient empty their bladder. Yes, we always empty the bladder first. So make sure to write down the 4 key points before a paracentesis. Then we can also give albumin IV to treat the hypoalbuminemia. Remember, albumin attracts water, transports drugs, and binds to calcium. So it attracts water like a magnet to bring fluid back into the vascular spaces to help decrease ascites, which causes an increase in blood pressure and bounding pulses as fluid gets drawn out of the abdomen and into the blood vessels. So once inside the blood vessels, we give eye-ending diuretics like furosemide to drain that fluid from the body and into the potty. Now, here's the key point for exams. How do you know if albumin has been effective? Well, write this down. We assess the vital signs. They must remain in, key term, normal limits. That's how you know if albumin has been effective. A big key point for the NCLEX there, so write it down. A lot of students get this wrong all the time. Now, don't let the NCLEX trick you here. Albumin effectiveness does not depend on the reduction of abdominal circumference with ascites, and it does not resolve muscle tremors or twitching in the arms and legs. That's mostly for hepatic encephalopathy. So remember, albumin is effective if vital signs are within normal limits. Now, in terms of nursing care, the first thing is diet. We always recommend low protein, which results with low ammonia and prevents hepatic encephalopathy. Next is low sodium and low fluid to get low swelling with that ascites. And obviously, no alcohol. We already have a scarred liver and we don't need more of that. And for malnutrition, we provide oral care before meals to wake up those taste buds. So the HESI mentions, the nurse is caring for a patient with severe liver cirrhosis and imbalanced nutrition. Which nursing intervention would prevent malnutrition in this patient? Provide oral care before meals. Yes, we want to wake up those taste buds. Next is the bleed risk from the low coagulation factors. So soft toothbrush, electric razor, and monitor blood inside the stool. Next is esophageal varices. As mentioned before, we always avoid Valsalva maneuvers, or basically bearing down like during bowel movements. Remember, any pressure can pop this esophagus. And no new NG tubes, those nasogastric tubes. No pressure inside the esophagus. Remember, this esophagus is like an overfilled water balloon, just waiting to explode with all that blood. Now lastly, pharmacology. Neomycin is used to decrease ammonia-producing bacteria. And lactulose we call lactolose. We lose the ammonia via loose bowels, but we also lose potassium too, resulting in hypokalemia, potassium less than 3.5. So we must expect low potassium and explosive diarrhea. Again, these are completely normal and to be expected. So don't stop giving the drug for loose stools and low potassium. We just monitor the potassium, since we lose potassium through the loose stools from the body and into the potty. So Kaplan mentions lactulose. We monitor for hypokalemia, that low potassium. Now for all the other key points on lactulose, let's watch this segment from the Pharmacology Master Course. Now lactulose we call lactulose, since it loosens the bowels to lower the ammonia levels. So we use the acronym LAC for lactulose. L for a laxative, A for ammonia levels that should be decreasing, and C for the cognition that returns. So keyword here is improved mental status. Now it's given to decrease ammonia levels in cirrhosis patients. It treats hepatic encephalopathy, fancy words for a cloudy brain, that decreased mental status from those high levels of ammonia. So guys, lactulose helps the body poo out all that ammonia. Basically, massive explosive diarrhea. So just think lactulose, we lose that ammonia. Now some common distractors on the NCLEX. Ammonia levels decrease via the bowel. Guys, not the urine, since it's not a diuretic. So no renal excretion of ammonia. And no, it does not decrease portal hypertension. And no, guys, abdominal distension will not improve with lactulose. Again, it helps us lose the ammonia in lactulose via those loose bowels. Now, how does a nurse evaluate the effectiveness? Guys, write down these key points here. Number 1, 2 to 3 soft stools per day. Number 2, ammonia levels are decreasing, but here is the key term. Write this down. Cognition must be improving. So we must have improved mental status. Guys, the biggest test tip I can give you here is don't let the NCLEX trick you. Diarrhea and loose stools are not indicators that ammonia levels are decreasing. The only indicator here is improved mental status. That's how you know the drug is working.
Thanks for watching. Did you know you can unlock beautifully handcrafted study guides, packed with key points and memory tricks from all our videos? Plus, you'll get access to over 1,200 exclusive videos not on YouTube, all neatly organized by nursing school topic, to make that complex nursing knowledge actually stick. You'll also gain thousands of practice questions written by current professors and actual NCLEX writers. So for access to all this and more, click right up here or visit simplenursing.com. And don't forget to subscribe to our YouTube channel. Happy studying, and we'll see you in the next videos.